Everyone, I can see all of you just starting to slowly join into the room here. So welcome to the Eye Health in General Practice session on tonight. My name's Hamish. I'll be helping to facilitate this session. So just first of all, I'd like to just do an acknowledgement of country for you all. North Western Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land in which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respect to elders past, present and emerging. So before we start the session, I'd just like to start with a bit of housekeeping for you all. Please just try and keep muted throughout the session whilst you're listening. Your microphone should be already muted as you're coming in and joining when we start. There is a questions and chat box just at the bottom of your screen. If you have any questions throughout the session, feel free to just put them in there, and then we'll have some time for some questions either during the presentation or just at the end. So yeah, if anything comes to you just in the chat box for you, we'll be able to answer that. So now it gives me great pleasure to introduce the speaker of our session today, Dr. Lance Liu. He's an ophthalmologist with an interest in clinical research that includes glaucoma, gonioscopy, anterior segment imaging, cataract surgery, and glaucoma practice patterns. Lance is involved in the Royal Victorian Eye and Ear Hospital Registrar Teaching Program and provides commentary for the Research Review newsletter. He's also involved with the Sight for All Foundation and the Australian Health Humanitarian Aid Organisation, which provides teaching and aid for cataract and glaucoma in Laos, Cambodia and Vietnam. So Lance, I'll now hand over to you to begin the presentation.
Okay, thank you. Let me just double check we got this in here. Okay, never can see my slides?
Yeah, we've got you
Can
there.
hear me? You got me there? Good, okay. First of all, thank you everyone for giving up your Tuesday evening to listen to what I have to say regarding eye diseases and some of the health pathways guidance that you may need, especially during these sort of pandemic times. I would like to thank the organisers for inviting me to speak to you today, and also to the audience for giving up your time to listen to what I have to say. I think this picture pretty much sums up where we are at the moment with COVID in Australia. We sort of nipped it in the bud, lockdowns permitting. We have problems with the vaccine, and obviously there's the ever threat of the variants that is that could derail everything. So tonight's agenda, I'm going to discuss the best practice when treating eye health concerns and recognise and implement local eye health referral pathways. And part of this is through the health pathways, which I'll talk about in a moment. And then we'll be focusing on pretty much the four main eye problems that the world faces at the moment. I'd like to identify some of the bulk billing pathways that may be present for some patients as such, and other services that may be available to your patients and how to access them. And that's in the form of some case studies here and what the Eye and Ear Hospital has to offer. Okay. So the Health Pathways is an online health information portal primarily designed for GPs. Basically, you have 700 locally agreed conditions and the guidelines on how to sort of assess, manage, and also when to refer. It provides information for patients, reference material, educational resources, and it's a pretty dynamic little website there. And the idea really is to maximize service delivery, improve communication between all healthcare providers, and it improves referral workup. So if you go to this website, melbournehealthpathways.org.au, you come up with the homepage here. On the left-hand side is a whole list of problems that you may face with your patients. And on the right there, obviously, some sort of quick, easy click on buttons there to access readily available information. And look, these days with the internet and everything else, gone are the days where you can sort of look up a MIMS, look out for a particular medication. These days, you just go online and you can sort of get it up pretty quickly on your iPhone or computer or things like that. So when we talk about eye conditions, I think it's best that we sort of, first of all, renew the ocular anatomy. I know it's been a long time for some of you as such, and I'll try and make it nice, simple and easy for you. So the eye is pretty much like this babushka doll. If you take a cross section there, you basically want to start anterior and work your way posterior, anatomical wise. So when you look at the patient front on, you see the eyelids there, you have the superior and inferior eyelid margins. They meet at the lateral and medial canthi. Behind the eyelids there, there's a lacrimal gland, okay, and the lacrimal sac. And tears are produced in the lacrimal gland, pass over the eyeball and drain into the lacrimal sac and down to the nasolacrimal duct. The eyelid itself is not just eyelashes and a bit of muscle, but in the back there are these meibomian glands that help maintain the tear film. And sometimes these can be blocked or get infected, leading to so-called styes, cysts, or chalazions. When you look at the eyeball anatomy itself, you've got that clear, transparent cornea surrounded by the white sclera and overlying thin conjunctiva. You have the pupil, which is surrounded by the coloured iris. Behind the iris sits the lens. And then behind the lens is the vitreous, a clear jelly-like substance that allows, maintains the shape of the eyeball, but also allows light to enter the eyeball. And then you have the retina. You have the so-called peripheral retina and the macula. And the macula is an important part of the eye because that's where you use, that's the part of the eye that sorts out the visual acuity and color and so on and so forth. All these signals then obviously transmitted by the optic nerve and on into the brain. So like anything in medicine, more mistakes are made in medicine by actually not looking than actually not knowing. So in essence, what does the eye do? Pretty much it takes pictures. It takes pictures of objects that are far away and in close up. So what are the common eye presentations that one presents with your patients there? Well, they come in saying that the vision's not very clear, they have glare problems, decreased night vision, distortion, or the new glasses aren't working. And from this, you need to tease out whether it's an acute or a gradual sort of thing. Is it there all the time, or is it just there only part of the time? Is the vision problems only for distance or for near, for both? And is one eye worse than the other? Other eye presentations that patients may present to you is pretty much a sore red eye. So when things settle down, sometimes you may want to do some opportunistic screening just to make sure that the rest of the eyeball is healthy once your initial problem has been sorted out. And then obviously diabetes, an increasing problem in our community as such, and they can be newly diagnosed. They can be a new patient that has been managed elsewhere, or it's an ongoing patient that you need to follow over time. So once you've taken the history, you need to test the visual acuity, and you need to do one eye at a time. You need to test the distance in each eye while wearing, and patients need to wear their glasses or distance glasses, if applicable, using either 3, 4, or 6 meter chart. If the vision is subnormal, you place a little pinhole in front of their eyes, get them to look through one of the holes, and get them to read the chart again. And then once you've tested their distance vision, you test their near vision with the patient's reading glasses if they have any as such. And then you may want to use an Amsler chart as well to test their central vision. How do you interpret what you've just done? Well, if the vision does improve with the pinhole, the patient may need some new glasses or may need to update the glasses that they've already got. And it's best just to refer to your local optometrist for that. If you find that the distant vision is poor, but the reading vision is pretty good, that is suggestive of a certain type of cataract, but not all cataracts. If the reading vision is poor, it is suggestive of some macular problem, such as macular degeneration. And then if the Amsler chart is abnormal, it does suggest some sort of macular disease there. So when examining the eyeball, if you're lucky enough to one of these slit lamps in your rooms, then it does make things a lot easier. However, I suspect most of you have one of these direct ophthalmoscopes as such. And look, it gives you a limited view of what you can see, not just the retina, but the rest of the eyeball. And what you're going to do is this: you've got to dial the numbers to sort of the green numbers to sort of +20, and it focuses us pretty close up. Then you dial it so the numbers decrease, go to 15, 12, 8, and then sometimes you may even go into the red figures. And what's happening is that the focal point or the focus of the direct ophthalmoscope moves posteriorly. So then you can focus on different parts of the eyeball as such. So once you determine that the patient is not going to give you COVID, you check their visual acuity here. Okay, so light from that then passes through the tear film, the cornea, anterior chamber, and then passes through the lens, through the vitreous, and hits the retina. With the retina, the light actually passes through until it hits the photoreceptors. The light energy is then converted into electrical energy, then passes up through the retina and through the nerve fiber layer, and then joins at the optic nerve, from which that then is then those signals are then transferred to the occipital lobe. Okay. So how do you know if the eye is working? Well, we test the visual acuity. Basically, it tests any problems from the tear film, cornea, lens, vitreous, all the way to the fovea. The Amsler chart pretty much is a test looking at the macula. So if the Amsler chart is abnormal, maybe something going on at the macula there. The visual field is testing the peripheral retina and the visual pathways there. And basically, you can do this sort of a crude confrontational test where you cover one eye, you get the patient look at your eye, and you're comparing your peripheral visual field with their peripheral visual field by sort of either showing how many fingers am I holding up or asking, do you see my finger in the periphery there? And finally, the optic nerve is like a whole bunch of sort of electrical wires as such, and basically you can test this doing an afferent pupillary, checking for an afferent pupillary defect by swinging the light from one pupil to the other to seeing the reaction of the pupil, and they're pretty equal on both sides. That's good, but if one paradoxically constricts and dilates, then they may have an afferent pupillary defect. And then you also then may want to test their color vision as well, if you think there's a problem with the optic nerve there. So pretty much COVID has forced us to adopt new technologies as such, like the Zoom meeting here. And pretty much the eyes are no different. So we've gone from the clinical examination with what materials that we have to pretty much technology. Retinal photography has been around for a long time, But now we've incorporated optical coherence tomography, or OCT, to give us more information about what is going on in the retina. So you have your digital fundus photographs, but the OCT provides like a cross-section or a B scan. So here's your retinal photograph here, looking front on or anteriorly. The OCT is this image here, where through this line, through the macula here, you can sort of see the architecture of the retina and the optic nerve. From there, you can compare the thicknesses with a normative database, and it can also give you some other fancy things such as thickness maps and pinpoint registration. So if you've got a lesion somewhere out here, you can click on it, and the OCT can then give you a cross-sectional image of that particular point to see what is actually going on. So, funny enough, the diseases that I'm going to talk about tonight make up about 80% of visual problems in the world. Obviously, the most common is cataract, but we also have glaucoma, diabetic retinopathy, macular degeneration, and refractive error. And funny enough, usually patients have one or more coexistent eye problems. So they may have a bit of cataract and glaucoma at the same time, or early macular degeneration as such. Or some cataracts can actually cause a refractive error. So it is important to pretty much examine the whole eye to see what's actually going on. So if we look at the topic of cataracts first, it is very common in patients, usually 60 years and onwards. There are three common types that are listed here, the so-called nuclear cataract, and this pretty much becomes more and more yellow. There's a cortical cataract, like spokes, which causes more glare problems. Posterior subcapsular cataract, which is accumulation of the lens epithelial fibers in the posterior part of the lens itself. And this one may not look like much, but actually is the most disabling. So what happens is that when people read, the pupil constricts and they say they can't read, or during a bright day, the pupil constricts and they can't see. But at night time, when the pupil dilates, they can actually see. So these may not look like much, but visually they are the most disabling. Then you have the so-called third world cataracts or mature cataracts, which unfortunately in our society we still do see from time to time, but it's not as common as, say, a third world country. So obviously the common symptoms that patients present with cataracts or have cataracts are a gradual decrease in the vision, whether it be for the distance, for near or for both, problems with low light vision, especially at night time, problems driving at night time. Or sometimes they think it's a glasses problem, they get their glasses changed and things work for a little bit and then things get worse. Or sometimes you see halos around lights. If a patient does present with a sudden reduction in vision, it is unlikely to be due to actually a cataract, although it does happen from time to time. And obviously when you look in with your direct ophthalmoscope, what you want to look is try and find the optic disc or the retina there. And obviously it's a bit cloudy here, but obviously most likely it's related to their cataract. And if you can't get a good view looking in, most likely the patient says, well, I don't really have a good view looking out. Using a direct ophthalmoscope, you can check the lens with opacity by just looking at the red reflex there, and you can sort of see this close up. And retinal photography can also be a useful screening tool for visually significant cataracts as well. So, what are the risk factors for cataracts? Age, we all get old, diabetes, corticosteroids, and mainly drops, creams, injections, and oral steroids can exacerbate cataract formation. Certainly previous eye surgeries like a fracectomy or trabectomy can also exacerbate cataract formation, and previous eye trauma, and I'm talking, severe blunt eye trauma in the past, can also cause cataracts. However, if cataracts are very common as you get older, they may have other coexistent eye pathologies such as diabetic eye disease, macular degeneration, glaucoma, or dry eyes. Now, at the moment, there is no standard visual acuity cutoff level as such. So the cataracts do affect the vision to certain degrees, depending on what the patient does. So someone who, say, fills multiple ships, well, they're more likely, they're more likely to notice something going on as to someone who just enjoys, walking down the beach or the street and having a cup of coffee every day. So really what you need to do is ask them exactly how much the vision is affecting their activities of daily living. And you need to consider their lifestyle and occupation. Driving, I think, is one of the most important things that we have in Melbourne. It's very hard to get around Melbourne without a car. So look, if the vision is 6/12 or worse in the better eye, so both eyes have to be equally bad, then obviously that's going to affect their lifestyle. However, even if completely lost vision in one eye and the other eye, the vision is still 6/9, 6/6, still pretty good, they can still function quite well. They may not be able to drive or fly a commercial airplane, but they can still drive a car and do other things. So in these sort of situations, you need to consider whether you need further assessment by the local optometrist or ophthalmologist, who can basically look more carefully with a slit lamp, also assess the retina and determine what type of cataract that they may have. Okay, so when does one refer these patients? Well, basically, following an optometry visit, so you've got a report with you, there's visual impairment that's affecting their activities of daily living. If there are potential for functional benefits, or the patient refers that they really want to get something done, you may need to refer them on to your local ophthalmologist or the public system. Vision Australia can offer some resources, but usually they would sort of suggest that the patients have their cataracts removed first, and before accessing their resources. And basically, look, the cataract is your natural lens in the eye getting dirty. This is it here. This patient's going to have a cortical cataract. This is the cataract being removed. And we pretty much replace the dirty lens or cataract with a new plastic lens. And that sits in the bag that holds the original cataract there. And pretty much that lasts, or it will outlive the patient as such. You don't need to remove them again as such. Most patients sort of say, look, are you coping? Yes, that's fine. Then maybe they only need a yearly optometrist visit. Other things they can do, some glasses may help, depending on the type of cataract that they have. Sometimes they need a bit more lighting to see what's going on. If it's related to the diabetes and steroid use, that needs to be looked at and controlled. Smoking cessation, I think, is important for any patient, not just for the eyes, but for the rest of the body. And there's the thing about reducing sunlight exposure, which is still a little bit of controversy as to whether it is related to cataract formation or not. But then again, a new pair of sunglasses will also reduce sunlight exposure to the eyes, especially in the hot Australian sun. So at this point, I'm just going to stop here. And I know that's a lot to take in terms of and the history and examination and things about cataracts. I'd just like to ask the audience if they have any questions at this stage.
No questions in the chat box just at this stage, Lance, but if anyone does have a question, feel free to unmute yourself or just put in the chat box. Okay,
then. All right. Okay, everyone knows all about cataracts. That's very good. Good and easy. So that's good. Okay. So anyway, you can see the hindsight symmetry here. I think we've gone through, cars and fires and things like that. Now we have face masks. I suppose when it comes to diabetes, if you don't control your sugars, you could end up like this. So in terms of diabetes and the eye, I like to coin the phrase diabetic eye disease, which consists of diabetic retinopathy. So we have damage to the peripheral retina, and diabetic macular edema or maculopathy, where the damage is now affecting the macula. Now the macula is located 2 optic discs, temporal and half an optic disc down, so around about this area here, or in this case here. So here we have a good example of severe diabetic retinopathy, and here these little things, or lipids, what have you not, is indication of macular edema, which is maybe affecting the macula. Now, the longer you have diabetes, the more likely you are to develop diabetic retinopathy, between 80 to 90% after 15 years. It is the greatest loss or cause of loss of visual loss in a working age population, and that's due to the diabetic macular edema or maculopathy, or if it's sudden onset, usually a vitreous hemorrhage secondary to proliferative diabetic retinopathy. So the thing is that patients may have severe diabetic retinopathy, but their vision may be normal because it's yet to affect their macula. So when you assess diabetic retinopathy, pretty much this is the severity level here of increasing diabetic retinopathy. So this is the normal retina. This is mild diabetic retinopathy. We see a few microaneurysms located here. The macula looks pretty good. You then have moderate diabetic retinopathy, where basically you have some hemorrhages there, a bit of lipid as such. Then you have severe diabetic retinopathy, where you pretty much, not only you have a lipid and hemorrhages, but the blood vessels start to look a little bit funny here, a bit more tortuous as such. And then obviously you go to the proliferative stage, where you have new vessels growing from the venous side of the blood vessels in the eye. Now, what's happening here is that you are having pretty much retinal ischemia that produces a substance called VEGF or VEGF, or vascular endothelial growth factor. And basically, you've got new blood vessels growing from the retinal veins. These blood vessels are leaky. So basically, they can break, leading to a vitreous hemorrhage. So up to this point, the patient's vision can still totally be normal. It's only when they develop a vitreous hemorrhage, or they've developed diabetic macular edema, that their vision is affected. So here's the OCT of the macula, and you see normally the macula sort of dips down like so. Here it's gone the other way. It's quite swollen, and this is sort of fluid-filled areas of the retina. But you can see here the diabetic retinopathy doesn't have to be too bad. Here this patient's sort of minimal to mild diabetic retinopathy. This patient here has got a vitreous hemorrhage, has also got the macula is here. So the lipid is coming very close to it, but clinically it's very hard to work out what's going on. You probably will need an OCT just to determine whether or not the macula is being affected or not. Again, the macula, 2 discs this way, half down, okay, looks pretty good, okay. This patient probably does have a bit of macular edema here because the macula is seated here amongst all this mess as such. And here we have some leaking blood vessels here, and the lipid or swelling is pretty much encroaching, if not affecting the macula in this case. So basically, certainly if you've got a retinal photographer machine, then take a picture. But these days, most of them will have an OCT attached to it as such. And there's a good way of safely monitoring diabetic eye disease. It's a good screening test for diabetic retinopathy, but you do need the OCT component to assess the macula properly. It's easy to use technology that allows early detection of retinal changes of retinopathy and also macular degeneration, because these changes of peripheral retina are asymptomatic. The patients are not going to know that they have retinopathy. It's only when it affects their macula or vision that they know there's something wrong. There is an MBS item number for those who are lucky enough to have one of these cameras. Unfortunately, it does only apply to GPs only. As I said before, cataracts are associated with diabetes. So again, if you're looking in, if the view looks pretty good, like here, there's very little or no cataract, but obviously if the view is not very clear, most likely they have a significant, visually significant cataract there is also affecting the vision, plus or minus their diabetic eye disease. In terms of diabetic eye disease management from a GP level, pretty much education, number one, and I like to establish the level playing field. I say to them, listen, you need to keep your sugars below 8 throughout the whole day. It's amazing how some of them will say, oh yeah, my sugar was okay, you know, this morning, but it went up to 12 or 13 in the evening. Also explain to them that the damage caused by the raised sugars is a permanent thing. And it's amazing how this is a revelation for some of my patients who've been diagnosed with diabetes for the first time. They sort of think, oh, well, as long as the sugars are okay, I should be fine. But when they hear that it's causing damage and the damage is permanent and that builds up over time, suddenly they start to think, okay, this is a lot more serious than what I think it to be. But I think if you establish that level playing field, then at least you know where you're coming from, the patients know where you're coming from. So at least then everyone is on the same level playing field. So if things do happen over time, then you can always go back to say to them, well, listen, I read you the riot act. This is what happens when you don't follow the advice. You also need to actively manage all the diabetes risk factors. So besides sugar control that I mentioned before, you also need to monitor the blood pressure as well. And if that starts to go off, you may also need to look at their renal function. Lipid control is also extremely important as well. And there are a number of medications that help with that. And obviously, if the patients are smoking, they need to cease straight away or get them involved in some sort of program to get them off their smokes, because we certainly do know that all these things accelerate the development of diabetic eye disease. So when does one refer patients with diabetic eye disease? Well, if their visual acuity is reduced due to macular edema, or if there's a sudden onset of vitreous hemorrhage, if they've got a bit of a cataract, there may be a combination of this and other things that's going on, and or they have severe non-proliferative or proliferative diabetic retinopathy, because these are the patients who are going to lose the vision fairly quickly due to the development of vitreous hemorrhage. Okay, so here the vision may be normal, but they have these sort of changes, they need to be referred. And basically, best to see your local optometrist, or if there's a sudden onset, or you see proliferative diabetic retinopathy, best to go straight to your local ophthalmologist, because these days we have treatments in the form of injections of anti-VEGF factors such as Lucentis, Avastin, Eylea, that pretty much mops off. There's free-floating VEGF factors produced by the ischemic retina, and pretty much you can see changes within 48 to 72 hours where all these blood vessels suddenly just disappear. And pretty much it's become the gold standard now these days in treating diabetic eye disease. Sometimes you can't seem to get hold of your local ophthalmologist as such, so you need to refer them to the public system. Basically, through the outpatients, you need an eye report, or sometimes what you need to do is refer them to the emergency department, especially in the setting of a sudden onset of visual loss due to a vitreous hemorrhage. Okay, so the vision is normal. You want to arrange an initial screening and then regular reviews. If they've been diagnosed with type 2 diabetes, they need to be screened fairly soon, because I think it's up to about 17% of patients who are newly diagnosed with diabetes have some form of diabetic retinopathy already. Type 1 diabetes actually can start about 5 years after initial diagnosis if the patient is more than 12 years old, because have yet to have developed the diabetic retinopathy as such. In terms of reviewing these patients, sort of if you have type 1 or type 2 diabetes, probably every 2 years. However, if they're not controlling their sugars or have other risk factors that can accelerate it, diabetic retinopathy, then they need to be reviewed annually. Certainly Aboriginal and Torres Strait Islanders need to be reviewed annually as well, and certainly if the patient is pregnant as well. And patients obviously with established diabetic retinopathy. And the reason why is that you want to stop these patients going from the non-proliferative to the proliferative stage of diabetic retinopathy. So if it's nil or minimal, and you can have an optometric review, or if you've got your own retinal camera, please use that. If you have mild to moderate diabetic retinopathy, I think it's best reviewed by your local ophthalmologist, because as soon as they can see changes, that things are getting worse, or they develop any diabetic maculopathy, then they can start treatment straight away. And obviously, the more severe it is, the more likely they are to progress to the proliferative stage. So that's pretty much diabetic eye disease in a nutshell. So at this point, I'm open to any questions that anyone might have.
So you've just had a question there into the chat, Lance. Is it possible to get diabetic retinopathy even if your BSL is under control?
The answer is yes, because they may have already pre-existing diabetic retinopathy due to previous damage, and you've got things under control. You can never get perfect control with diabetes, so certainly having your sugars well controlled reduces the risk of further progression. But eventually, if they have diabetes long enough, they will eventually get some form of diabetic retinopathy. Maybe not enough that requires treatment, but they will all get some eventually. It's hard now with these sort of insulin machines that some of my patients have been coming in with, and their sugar control is certainly a lot more superior to the tablets and the insulin injections that we had, which used to be the mainstay. And look, said it would be interesting to follow these patients over time to see whether or not their risks of diabetic eye disease and other diabetic complications is reduced or not as such. And don't forget, it's not just the sugar. There's the cholesterol, there's the blood pressure, there's the smoking, and all those other things. So even though the sugars may be well controlled, there are other things that can cause microvascular disease that can also lead to retinal ischemia. The other question I see here is, do all retinal cameras have an OCT? All I can say is all new retinal cameras pretty much come with an OCT. They cost a lot more. All the old cameras, certainly not. Again, it's something that has been around now for probably, say, 12, 13 years. And it's become pretty much, it's allowed us to pick up earlier damage or diabetic maculopathy as such. And the cases have to do what we used to do in the past, which was called a fluorescein angiogram, where we injected dye into the patient's veins and took pictures of the back of the eyes to see whether the dye was leaked into the eye or not. If it was, they pretty much needed treatment. But these days with the OCT, we can actually see swelling, so we don't need to do the fluorescein angiogram. It's non-invasive, but unfortunately, it is a bit more expensive than your old-fashioned retinal camera. Okay, another question here. Who should tell a client that they are not able to drive legally? There are a few clients that are going for treatment for. Good question. Okay. I think basically it depends on what is causing their vision problems and what treatment's available to them. So if a patient comes to me with reduced vision that does not meet the criteria for driving a car, I say up to them up front that, listen, technically you're not allowed to drive a car because you don't meet the VicRoads criteria for holding a license, okay? I qualify that by still saying that, listen, I am under no obligation to let VicRoads know that you have poor vision, okay? But I do say to them that if they were to continue to drive and have an accident and the car insurance found out, they will not pay up. And sometimes patients obviously are quite shocked by this. If they're there with a family member, especially a younger one, that's actually quite a good thing to do because you tell the family as well. They get the family involved and say, listen, we have a problem here. You're technically not allowed to drive anymore. But ultimately, I leave the decision up to the patient. I've had one patient I do remember who had lost half his peripheral vision due to a AVM malformation in the brain. And he continued to drive despite me saying he couldn't, me writing letters to the GP, his local optometrist, and even having his son there. And he says, without the car, I cannot survive. So what I do is I drive slowly and I turn my head from side to side using what vision or visual field that is not affected by his AVM to see where he's going as such. Yeah, that's what happens when you've been around for a long time. You do see some of these patients as such. So look, I think at the end of the day though, if a patient has an eye problem that can be treated, so say diabetic maculopathy that can be treated with injections, or a visually significant cataract that can be removed, that may improve the vision enough that they can continue to drive. It's only when you've tried all these treatments and the vision hasn't really improved, then I think it dawns on the patient that, yes, I will have to give up the license and things like that. I hope that answers your question. But the thing is that there is no right way to tell a patient that they cannot drive again. You know, it is a hard thing to do, and it's one of the hardest things I have to do with my patients as such. But like I said, I think it's best to have the eyes assessed first, see exactly what's causing a problem, fix up those problems, and during that time, certainly you'll be able, I usually will entertain the idea that maybe you may not be able to drive anymore. And I certainly have had patients where we've tried things and unfortunately they've just missed out on their vision-wise. And the other way around, I've had other patients in which things, the vision's improved so much after removing their cataract that they're allowed to drive. And I say, fine, fantastic. Let's leave things as they are. Any other questions from the audience regarding diabetes or cataracts? No? Okay. All right, well, I'll just keep going then. Now, glaucoma. So glaucoma is disease of the optic nerve. It's due to degeneration or loss of retinal ganglion cells that causes changes to the retinal nerve fiber layer and the optic disc. So here, this is a normal optic disc. It looks like a donut. You've got the yummy bit on the outside, you've got the hole in the middle there. And over time, there's progressive loss of the nerves. And so what happens is the hole in the donut gets a lot bigger. And it is the first cause of irreversible blindness in the world. It's related to the eye pressure being too high, and basically it affects the peripheral or side vision first, but the central vision is the last to go. So patients still say, I can read and watch TV and everything else, I just didn't see the bus coming down the road when I crossed the road, sort of thing. So that's usually the things that they, symptoms they present with. It's common in about 6% in over 60-year-olds. So again, disease of the older population. Overall, it's about 3% in Australia. And again, as I said, it's a leading cause of irreversible blindness. And the thing is that patients may have glaucoma, but you need a lot of damage before they start to lose their vision. So again, they usually present very late. There are two types, the so-called chronic and acute. Now, the chronic, again, divided into open angle or angle closure, depending on what the drainage system looks like. And I'll show you a picture of that in the next slide. The acute angle closure glaucoma, now known as acute primary angle closure, basically it's a rapid rise in eye pressure due to closure of the anterior chamber angle, causing blockage of the IV drainage pathway. This is not very common, but it is a devastating and blinding disease. Risk factors, again, age. If there's a family history of glaucoma, their risk is about 10 times more. Now I'm talking primary relatives, so mother, father, brother, sister. Steroids. So ongoing steroid use. Now, again, form of eye drops, creams, injections, tablets potentially can make the eye pressures go up in some patients. And the pressures may go up, you know, to 30 or 40, but again, the patient doesn't actually realize there's a problem with their vision. And certain ethnic races, such as the Asian population, are more at risk of developing certain types of glaucoma, such as acute primary angle closure or angle closure glaucoma. The open, or whether it be open or closed, basically it's the peripheral vision is affected first, followed by the central vision. Patients with angle closure, though, may have preceding episodes of periocular ache. So they might sort of say, listen, I've got this funny pain, ache, or headache around the eye. I find the vision is not very clear, hazy or blurry at times, and it clears up again. Or I see circles or halos around, or rainbow colors around lights as such. And sometimes, more often than not, these symptoms are diagnosed as either sinusitis or migraine, or they actually are due to angle closure, which can lead to acute primary angle closure later on. So here, a cross-section of the eye here, this is the drainage system here. And if I can stop that and go back. Okay, so this is the cornea, this is the iris, this is the lens, and this is the drainage angle here. So you can see when the pupil is constricted, say in the sun or during the day, the angle looks open. So what happens is that when the pupil dilates in the dark, it becomes shut. We use a laser iridotomy to open it up. And more recently, we've worked out that if we take out the lens or cataract, it even opens up the angle even further as such. So some patients, not all patients, have these pre-existing so-called sinusitis or migraine signs. They can present just very suddenly, basically painful red eye, headache, nausea and/or nausea, vomiting. The cornea is hazy, the pupil is mid-dilated, fixed, the eye is very red, the globe feels very tense, the eye pressure, we're looking like 50, 60, 70, with a normal sort of less than 22. This is one of the few ophthalmic emergencies that we have, because if we can get them to get a laser iridotomy performed, we can open up the angles or do other things, open up the angles, lower the pressure, and that in turn, so their symptoms are resolved and the risk of them going on to develop glaucoma is reduced. So again, someone who presents like this, you need to get onto your local ophthalmologist, preferably, or the emergency department. Now, there are some therapeutically endorsed optometrists that have done a course, and they are allowed to actually prescribe medications first line as such. So for those with chronic glaucoma management, basically you need to refer your local optometrist or your local ophthalmologist or even the public hospital. Now, if you do that, you do need an eye report from your local optometrist or ophthalmologist. I'll talk about that a little bit later on in terms of referrals. Patients who unfortunately have lost a lot of their vision from their glaucoma, there are Vision Australia resources that help with them, or the Royal Victorian Institute for the Blind. And look, because like diabetes or any other sort of long-term health problem, it involves a bit of collaborative care, not only between the ophthalmologists, but yourselves, the GP, and or the optometrist. So basically, look, if you think you're going to put someone on some long-term steroids or even short-term, best to maybe get their eyes checked, eye pressure checked in a couple of weeks' time, just to make sure the pressures haven't gone up. The glaucoma medications that we use have certain side effects. So something like beta blocker, timolol can cause asthma or breathing problems. Alpha-GAN can make you feel tired. Xalatan and things like that can make the eyes a little bit red, make the eyelashes grow a bit longer. Compliance is a problem because these drops have to be taken every single day for the rest of their lives. Some patients, again, are quite shocked when you say that to them. And so obviously their scripts need to be given. It's amazing how sometimes they say, oh, I've run out of my last drop. I'm seeing the eye doctor next 2 weeks. I'll just hold off until then. It doesn't sort of go with the advice that these drops have to go in every single day. But more often than not, a lot of my glaucoma patients at one point in time will forget to take their drops, lost their scripts or things like that. For those who have a family history of glaucoma, again, primary relatives, but once they hit the age of 40, they should have their eye pressures checked, their angles assessed, and the optic nerve photographed either by the optometrist or ophthalmologist, because it can take many years to see changes of the optic nerve. So basically, as much as I like to say I can remember what my patient's eyes looked like 10 years ago, you can't argue with a photo with these patients. If you've got a retinal photography machine with you, it is a poor screening test, but a picture of the back of the eyes at one point in time is important, because who knows, 5, 10, 15, 20 years down the track, they may develop glaucoma. You can always go back to that photo and say that listen, they're normal now. Things look like they've changed. The diagnosis of glaucoma is confirmed. This one I haven't heard before, but yeah, it makes sense. When you reach that ripe old age of 40 plus, where the reading vision is getting worse, you know, they immediately say, let's go to the pharmacy, get some reading glasses and they see a bit better. But maybe the best thing to do is actually say to them, listen, why don't you go to get the local optometrist or the eye doctor, get your eyes checked, because they can check the rest of the eyes for other problems, see whether or not you have this thing called glaucoma, or you're at risk of developing glaucoma or some other eye problems as such. And so-called sort of opportunistic screening, because unfortunately a lot of eye diseases can present quite late when the vision is affected. By that time, sort of the horse has already bolted. Okay, macular degeneration. Now, this is a disease that affects the macula, that affects pretty much the reading vision. And basically, it starts off with no signs of macular degeneration, to subclinical, to early, to intermediate, and to advanced. And pretty much early, if someone has early macular degeneration, they have about a 3.1% chance of developing advanced AMD over time. If they have intermediate changes, then it's about 47.3%. Again, they may start off saying that, listen, I don't see so well at night time, but it's a very subtle sort of symptom. It's a very soft symptom because usually these patients have a bit of cataract as well. So is the dark adaptation because of the macula? Is it because of the cataract? Or sometimes it's both. As such, most patients present at this level of advanced AMD when they notice a change in the vision, and that can be a gradual or sudden onset. So we start off with late or advanced macular degeneration. There are two types, the so-called dry type and the wet type, the dry type being the more predominant form. And basically, you just have atrophy of the photoreceptors and overlying retina involving the macula. In the wet type, usually what you have is a bit of damage, but also swelling of the macula. And again, you confirm that with an OCT. So normally, this is the retinal pigment epithelium. It sort of goes across like this. But here we've got a big lot of fluid that's has caused this to swell, and that's why the vision's affected. Again, one of these things which occurs commonly as you get older. There may be a family history. And it's more common, the wet form is more common in patients who have been smoking either currently or in the past and actually has stopped. And there's a lot of other papers to show that patients with cardiovascular risk factors are at more risk of developing the wet form of the macular degeneration. And this study, this little thing here shows in Australia, you can see that the older you get, the more macular degeneration that we see. So, of the wet AMD, sudden change in the vision, distortion of the vision, including straight lines, or there's a persistent new blurry patch in the vision. So this is the ambulatory chart that we talked about before. With the patient's reading glasses, you'll get to look at the little central point here. Then you ask them whether the lines around that are crooked or straight. And if they have, if it's crooked or missing or whatever else, then there's a problem with their macula. Whether it's related to the dry or the wet type, you again need to that needs to be assessed. So the stage before the late is the intermediate. And what you see is these sort of large, look like spots here, yellow spots called drusen. They're medium size and large size. Sometimes you start to see little black spots as well called RPE changes as such. And these patients, again, the vision may be impaired, but like not too much, just very minor. And if you do the OCT, you can sort of see instead of this, the RPE being straight, it's very bumpy, and this is the little spots that form here. The stage before intermediate is the early AMD, and what happens is these spots are actually a little bit smaller as such, small drusen, small little drusen here, small little dots here. Again, usually the vision is not affected. Okay, so if you see drusen or the vision is affected, you need to arrange an optometric or ophthalmic assessment. And basically, if it's early or intermediate, we just give them an ampular chart to monitor their vision every day. I get the patients to stick it on their fridge. They get up in the morning, put their reading glasses on, test one eye, test the other. And I say to them, if each day it looks the same, fantastic. If it changes, you need to contact the rooms to see me earlier. If it's obviously if it's late macular degeneration, basically you need a prompt ophthalmic assessment, and basically we treat these with anti-VEGF injections into the eye, which should be started soon, and patients should stop smoking. So I'm sure you have patients who are undergoing treatment for macular degeneration. So basically what we do here is we clean the eye with a bit of betadine to reduce the risk of an infection. We put a speculum to keep the eyelids open. so the patient doesn't inadvertently squeeze their eyes or close their eyes when they're doing things. Some give injections of topical anesthetic, some give a local anesthetic, and the idea is to inject the medicine into the vitreous cavity, and it's usually about 4 millimeters behind the limbus there. Okay. And these injections are pretty good because they do two things. One, in about 30% of cases, they can actually improve the vision in patients. At the same time, what they also do is that they stabilize the vision or stop it from getting worse. So we usually start off with one injection every month of the first 3 to 5 months to improve the vision as much as we can. Then we give less frequent injections just to maintain the vision that they've actually gained. And certainly, look, before these injections, most of these patients went blind within sort of 18 months. These days, we can maintain the vision for many years to come. Such, the only problem is that the medicine only lasts a certain period of time. So for some patients, they may require injections every 6 weeks to 4 months. As such, and unfortunately, yeah, it is a burden not only on themselves but the carers, but also the eye services as well. There's a lot of research going on to whether you can use a drop form or things like that, but unfortunately, the molecule's just too big, or you don't get enough concentration into the back of the eye where the pathology is. Okay. So if it's late AMD and it's of the dry type, basically you just need an annual retinal assessment by the optometrist there. Now, some patients with the dry type can develop the wet type later on, and vice versa. Some with the wet type can develop the dry type later on as well. You may have heard of nutritional supplements, such as Macuvision and things like that. These are pretty much based on sort of flimsy surveys asking you what you 8, 10 years ago, 15 years ago. I can't even remember which hot restaurant I went to last week, so I'm not sure how accurate those sort of things are. Very important that if they are smoking, that they can stop smoking as such, and obviously if they have very poor vision, they can be assessed, they can be sent to the Vision Australia, where they may be able to help with visual aids and things like that. So yeah, road back to normal with a lot of lockdowns and what have you not. Again, any questions or queries at this stage about anything that I've had to say? Oh, might have a little thing here. Is it expensive to have an injection, or is it bulk billing? Yeah, good question. It depends on the ophthalmologist and what they charge. As such, some bulk bill, some charge a co-payment, some charge quite a lot. It all depends, I suppose, on where you are and what the local ophthalmologist does. The problem is that, and it's been estimated that you need about 83 patients or something else like that, and then your eye clinic is full. All you'll be doing is giving injections all the time. So we are finding very hard ways to try to stretch out the time between injections or things like that, because it is becoming quite a big burden on what we can do, because we can't see new patients or other patients who present with other visual problems or things like that. Well, let's just keep going then. Okay, so one of the other things I want to talk about is referral pathways. And look, depending on what the symptoms, visual acuity and ocular findings are, you guys may need to manage the underlying problem. If you feel, if you have the facilities, you may decide to observe these patients. They may require further investigation, or they may require additional investigations and or management. So usually your first port of call is either your local optometrist or local ophthalmologist. who in turn may be able to fix the problem or refer to the eye hospital or the public system. Now, if you need to refer the eye hospital, they need an eye report from the either local optometrist or local ophthalmologist as such. Or sometimes we refer you back to you guys, and you have a chat about what's going on, and the patient says, listen, I really can't afford it. I need to go to the public system, so you may refer them there. But again, very important that you send an eye report with them. Now, you may be aware of some other eye services there, the Aboriginal Community Controlled Health Organisations, the Rural Workforce Agency Service, and Vision Australia. And certainly they may be help with some of your patients as such in terms of getting eye care. Okay, so these are the eye hospital referral guidelines that I got off the internet. Basically, for patients with diabetic eye disease, retinopathy, diabetic macular edema, vitreous hemorrhage, again, they need a retinal assessment with an optometrist or ophthalmologist, and then can be referred. Cataracts, and basically they look at the best corrected visual acuity with distant glasses. Again, you'll need a report from your local optometrist or ophthalmologist. And then it really depends on how bad it's affecting the vision. These are some of the tips that you have, but basically it's got to be, the better eye has to be 6/12 or worse with the new glasses, or things are really, really bad, or if they're a professional driver, such as a truck driver or things like that, if they have one good eye, or they're at risk of falls. So all those is taken into consideration as to whether they get an appointment. Now, with the current COVID situation and everything else, and plus that the public system was not very good prior to the COVID, this pandemic, the wait for a routine appointment at the moment has blown out. And I'm talking sort of maybe 1, 2, 3 years. If you happen to live in Brisbane, my friend who works up there says it's 7 years to see the public system, the Royal Brisbane Hospital public system there. So that's how things have become, especially, and the COVID has certainly exacerbated things. So there's certainly a lot of patients who come to see me in which they definitely cannot go privately, but I say to them, unfortunately, the public system will not take you because you don't meet their guidelines. Invariably, I will send a letter to them, and invariably the letter will come back saying, you do not meet the guidelines, please read the guidelines, please only refer us the patient back when you've met the guidelines, and even then there'll be a long wait. That's just the eye hospital. I do know the other public hospitals are also under increasing strain to see the backlog from last year as well. Northern Hospital in particular, and things like that. So unfortunately, there's not much we can do with a system that, as we all know, is suboptimal at the moment. For wet macular degeneration, again, need a report as such. Now, because these injections are all ongoing, the eye has basically said that, listen, we are happy to see them. We will only give the first 3 injections for any new patients. Then the patient has to find their local community ophthalmologist to continue their treatment. If they are already receiving treatment outside and want to come to the eye hospital, sorry, I won't accept them as such. Why? Because basically they do not have the resources to treat all the patients with wet macular degeneration. It's interesting, when these injections came out in about 2006 or 7, it's amazing how my colleagues who specialize in the medical retina side of things all basically said, don't worry, send them to us, we'll give all the injections, you don't need to worry about it. Within a year, a lot of them sort of said, oh, listen, I'm happy to give you the first 3, but look, can you continue the injections afterwards? It's not that hard to do. I will teach you how to do it, because pretty much their clinics became overwhelmed with all these patients. And you can understand a patient that comes back every couple of months for another injection, it just builds up over time. When it comes to glaucoma, again, it's getting worse. It's pretty bad. There are narrow angles for angle closure. The end stage or pretty advanced. Basically, you need a report from your local optometrist or ophthalmologist before they will actually see them. Okay. So some of you may be aware of the Rural Workforce Agency Victoria outreach. Pretty much it facilitates culturally appropriate, affordable eye procedures at the nearest available location, and pretty much prioritises Aboriginal and Torres Strait Islander patients living in rural and remote Australia. They're able to fast-track surgery by providing financial support for surgical fees for those living in large rural or remote areas. If they're living in the city, then they can fast track through the public system. Again, it doesn't cover any private fees. It all pretty much goes through the public system as such, but at least they can provide money for transport, meals, accommodation, fuel support, and things like that. Basically, depending on where you work, this is the websites that you go to, and you can look at what's actually available and what incentives that your patients may be eligible for. And there's also an outreach service as well. You may note here that I did look at the website here, and as of July last year, I made some mention about putting a hold on patients accessing this for the moment because of the COVID situation. Okay. So here's a case study here, not one of my patients, I should say. A 33-year-old type 1 diabetic was contacted by the Aboriginal health officer, the practitioner, and basically said, he needed a retinal screen. He had previous laser surgery before, but no record. And look, if you've had previous laser surgery, it means that they've already got pretty established diabetic retinopathy that need to be treated. He had some retinal photographs taken, and it showed high-grade changes of proliferative diabetic retinopathy. And obviously, the doctor did the right thing in referring him to the ophthalmologist, but unfortunately, he did not turn up because he was worried about the costs. So the ACCHO rang the ophthalmologist for the eye clinic and basically arranged for the patient to be bulk billed. And we saw the ophthalmologist had further laser treatment to treat his proliferative diabetic retinopathy to maintain the vision that he's got, to stop it from getting worse as such. And then the patient was also reviewed for his other diseases as such. So here's a situation where, look, you have some patients who just cannot afford it, or for whatever reasons don't want to pay. And look, sometimes you may want to speak to your local ophthalmologist or whatever else and say, listen, this patient's in a hard situation. Can you see what's going on first, and then take it from there as what needs to be done? And I think a lot of us are quite happy to provide some sort of care, or certainly referrals to the public system as such. Either way, to get into the public system, you still need an eye report from the optometrist or ophthalmologist per se. So if we go back to the HealthPathways Melbourne, as such, you go down, you click on ophthalmology, you click on diabetic retinopathy, and pretty much it's pretty good. You've got a checklist of all the things that you need to look at: risk factors, checking the visual acuity, looking for cataracts, and range screening and photography, and so on and so forth. And depending on what you find, you may observe them. They may be referred for ongoing treatment. So it's like a little checklist as such. Could be a little bit updated in terms of, because it doesn't, this severe non-proliferative diabetic retinopathy threatening vision, this thing doesn't actually include diabetic maculopathy, again, this is just something that we just refine the definitions a little bit, that has yet to get to the main literature. Any questions regarding this case at this stage? I'll say no. Okay.
No questions, it appears.
No questions.
Right.
Okay. Well,
keep charging on.
I'll keep going. I'm running out of things to say, but then again, I'm sure a lot of you are getting hungry out there as such. So, second case study is an 82-year-old type 2 diabetic, again presented to the ACCHO, saying that there's been some changes. There's some retinal photographs taken and then referred to his ophthalmologist. Was actually found to have dense cataracts in both eyes, worse than the right. And basically, it was prioritised to have cataract surgery through the Eye and Ear Hospital. And basically, fortunately enough, it all went well. He's seeing a bit better, and now waiting to have the left eye done. So again, and there are some patients who are like this, who things can be prioritised. And certainly, look, you know, the Eye and Ear Hospital is not a heartless hospital, although some people believe they are as such. But unfortunately, look, they are doing the best they can. It is hard to filter a lot of patients that come through as to who needs surgery and who can wait. Again, if you go back to the HealthPathways, again, go to the website there. And again, same thing. A little bit of background about cataracts that we talked about before, in terms of the preoperative assessment and what you'd expect in the postoperative period, in terms of also then sort of managing as well if they're still waiting to be seen or things like that. Or sometimes what happens is patients, they don't meet the guidelines initially, but then over time the cataract gets worse, the vision gets worse, so they can be reassessed again. And then if they do meet that threshold, again, they can be referred to the public system. This probably summarizes everything that's happened in the pandemic. You know, social distancing, quarantine, lockdown, so on and so forth, wearing masks and all that sort of stuff. So I'm sure we can all relate to this in one form or another. So in saying that, I've pretty much come to the end of my talk. So any final questions or queries about anything that I've had to say, or any other eye problems that patients, the audience may have come across, or any pearls that you may like to share with everyone else, or everyone's just gone to sleep and or gone to dinner. Oh no, you got one here. You got one here. How long should a patient wait after surgery of one eye if he needs a surgery for the other eye? Good question. As I mentioned before, 15% of the population function with one eye quite well. So as long as the vision is good in one eye, in the majority of cases, they can wait for the other eye to be done. The priority is given to patients with what they call anisometropia, where the refraction or the glasses they need between one eye and the other is quite a marked difference, and the patient's having troubles seeing out of both eyes. If the success of the first eye or the vision has improved so much for the first eye, and they're still having affecting their activities, daily living as such, they're the sort of main priorities as such. Unfortunately, in this lovely, wonderful, perfect world of ours, unfortunately, there's always going to be a wait, especially in the public system, of getting the second eye done. And some cases will be prioritised over others depending on the problems that they may have. I hope I've answered that question anyway. Can we get a copy of the slide presentation? Sure. I'll send a PDF to the powers that be. They can send it to you all as such.
Yes, the follow-up will be sent out to everyone that's attended the session tonight, where there'll be an evaluation survey as well as the presentation as well, so everyone can get a copy of that. There'll also be a recorded posted online as well if anyone would like to rewatch it.
Okay, another question from Sonia. Are younger people still in the workforce whose vision is getting worse a priority, or go to the end of the list due to a younger age? No, it really depends on what the corrected visual acuity is and how much it's affecting their lifestyle, their work, and things like that. I'll cite an example that happened during lockdown 2.0 last year. A patient came to see me. He had the posterior subcapsular cataract that I showed before, the one that affects the vision a lot when you're reading or things like that. Now, he was the sole provider for his family. He was working from home. He couldn't see the computer. He had pretty much a mature cataract, or almost mature cataract, in one eye and a very dense posterior subcapsular cataract in the other eye. The vision in one eye was hand motions. The other eye was about 6/9 just, but 6/9, but like still very blurry, can't really see very clearly. I had to go through, I tried to get him done as an emergency, and sure enough, one hospital rejected it based on the fact that his vision was still good in the other eye, even though it wasn't great vision. Where I work at the Eye Hospital, I had to go to the powers that be. I had to plead my case. I actually had to get a senior consultant that I knew quite well to ring me to ask what was going on. I explained to him the situation. So fortunately, he had one eye done. He's seeing a lot better, very grateful. He's yet to have his other eye done. Okay. So he was about mid-40s or things like that. So bottom line is, yeah, it is based pretty much on the best corrected visual acuity and how much it's affecting their daily living.
Anybody else got any questions for Lance this evening? Feel free to take yourself off mute as well if you'd like, or just into the chat function. Perhaps there was an area discussed this evening that you'd like us to go back over again and go into further detail?
No.
Or it was just an excellent comprehensive presentation.
Yeah, common sense and compassion. Yeah, I think it also depends on who you speak to as well. It's amazing how when you work with your colleagues that work side by side, we seem to have a lot of this, but when it comes to administration, I think we've all been a victim of a lack of common sense and compassion sometimes. They need their arms twisted, but look, at the end of the day is that there are ways and means of getting things done. It really depends on each individual patient and the clinical findings. Okay, I think we're done. I think everyone wants to go to dinner.
It certainly does seem that way. So look, if no one's got any more questions for us this evening, if you do have any that come to you after the presentation ends, feel free to put those questions in the evaluation survey that will be sent around to you tomorrow morning. I've also